Warm greetings to one and all. I would like to thank AOS for giving me this opportunity to talk on the interpretation of OCT reports. These are my financial disclosures, nothing particularly of interest to the topic which we will be discussing today. Jumping straight onto the topic, first we will discuss the interpretation of the ONH and the RNFL report of Cirrus OCT. So we will stick to the discussion of 2 or 3 most commonly used OCT devices so that anybody using any of them would have some idea or gain additional knowledge on how to interpret the OCT reports specifically from those OCT machines. Here is the Cirrus ONH and the RNFL report. The interpretation of the report starts from looking at the patient details. The important things to note here are, like the visual fields, the date of birth, because the structural parameters of OCT on these reports are compared with age-matched reference database. In addition to age, the other most important parameter here to pay attention to is the signal strength. If you can see here, the signal strength of the right eye is mentioned as 7/10 and of the left eye as 8/10. Generally, the OCT manufacturers recommend a certain level of signal strength beyond which it is an acceptable scan and below which the quality of the OCT scan, which is primarily the OCT signal, is suspect and caution needs to be used before interpreting them. So age and the signal strength are the important parameters to look for in these patient details. The next important zone on the report is the RNFL thickness map. Here, the RNFL thickness around the optic disc is represented using pseudo colors, the scale of which is given on the left. Thicker is the RNFL, brighter are the RNFL colors, more orangish, reddish, yellowish represent thicker RNFL. And as normally expected, we see the thickest RNFL bundles at the poles of the optic disc inferiorly and superiorly. The next important zone to look for on the report is the RNFL deviation map, where the RNFL thickness at smaller regions called superpixels are compared with age-matched reference database, and they are highlighted if they are significantly different from what is seen in an age-matched normal. The next zone to pay attention to on the reports are the tomograms. Though not much attention is paid to these are very important regions to look at, and I'll tell you subsequently why they become important. But one thing to pay attention to is to look at the segmentation of the structures on these tomograms. As you can see here, on the lowest tomogram, which is called the RNFL circular tomogram, there are 2 lines marked here, which represents how the machine has demarcated the anterior and the posterior border of the RNFL. The next important zone is the quadrant and the Clark maps, where the RNFL thickness around the disc in the calculation circle, which is represented here, is shown in the 4 quadrants, 90-degree quadrants, superior, nasal, inferior, and temporal. And the RNFL thickness in smaller regions is represented using the Clark R's. So the RNFL thickness is also given in Clark R's, primarily not to miss any small region of RNFL thinning, which is called focal regions of RNFL thinning, which can be missed when they are averaged over larger regions. The next one is the T-SNIT graph. T-SNIT graph represents the RNFL thickness over the entire 360-degree calculation circle. starting from temporal and going anti-clockwise. Here, the right and left eye RNFL thickness is superimposed on each other to look at any discrepancy between the right and left eye. This is called the symmetry of the RNFL thickness. The T-snit graph is also provided for the neuroretinal run thickness here, similar to what we discussed for the RNFL thickness. And any gross discrepancy or asymmetry between the right and left eye becomes obvious here. The next region is a small table which gives the summary parameters here, the average measurements of the disc and the RNFL. So all of these are color coded to represent how similar or how different the patient's RNFL and ONH parameters are compared to the age-matched normative database. The current generation OCTs also evaluate the inner retinal layers at the macula. The Cirrus OCT evaluates the inner two retinal layers, which is the ganglion cell layer and the inner plexiform layer, together called the GCIPL layer. This is called the ganglion cell analysis, or the GCA. This is how the report of the GCA looks like. And once again, interpretation starts with patient details, the date of birth and signal strength being the important parameters to pay attention to. Then the GCIPL thickness map, very similar to the RNFL thickness map. The thickness is represented using pseudo colors. Brighter the colors, the reddish, orangish, yellowish, thicker is the GCIPL. Deviation map, once again similar to the RNFL deviation map, where the GCIPL thickness in the superpixels of the patient is compared against the age-matched reference database and color-coded to represent how similar or how different it is compared to age-matched reference database. The sector map, the GCIPL thickness of the scan is divided into 6 sectors, and the GCIPL thickness in these smaller 6 sectors is represented in the sector map. And all of these regions, the sector map, deviation map, are color-coded to represent how similar or how different the patient's or the subject's thickness here is compared to age-matched normative database. And as you all well know, the white here represents that the GCIPL thickness in this sector is thicker than 95% of the subjects in the normative database. Green represents the patient's thickness being between the 5 and the 95th percentile values. And if it is thinner than what is seen in, or the thinnest 5 percentile of the values is represented using either a yellow, or the thinnest 1% is represented using red, as you all know, which we will discuss subsequently. Tomograms once again are used to see how the segmentation of the GCIPL has been done by the OCT machine. So the findings in glaucoma, here is an example of a glaucomatous left eye, which shows inferior rim thinning and an obvious inferior retinal nerve fibrillary defect, well appreciated on the red-free photograph here. The visual fields of this eye shows a superior nasal defect, superior arcuate defect more in the nasal region, which is more obvious on the 10-2 visual fields, which represents the damage being more closer to the fixation. And the Cirrus OCT of this eye shows good signal strength. The tomograms are okay with the segmentations appearing okay. And if you look at the thickness map, shows that the bright band which needs to be present inferiorly is missing. So these are the cooler colors which represent the RNFL being thinned out inferiorly. The deviation map also shows that corresponding region in red and yellow, which tells us that the RNFL thickness in all these regions is significantly lesser in this eye compared to an age-matched normal. And the quadrant and the clock hour maps also show RNFL thinning in the respective region. On the GCIPL map, once again, we see the thinning of the GCIPL in the inferior region corresponding to the region which is thinned out on the RNFL. Another example of a glaucomatous patient with the inferior rim thinning and a small retinal nerve fibrillary wedge-shaped defect inferiorly in the right eye, and inferior notch with a broad wedge-shaped RNFL defect inferiorly in the left eye. Here I've used the structure function report available on this Cirrus OCT, not only to show the defects on the RNFL, which is shown in the inferior RNFL thinning here and a broader layer of inferior RNFL thinning on the left eye, but this also superimposes the region of the RNFL thinning with the corresponding mirror image sector of the visual field in the structure function maps here. So here on the right eye, we see that the region of RNFL thinning matches very well with the region of the visual field defect on the visual field, while in fact the region of RNFL thinning is slightly more than the region of visual field defect. And in the left eye as well, the region of visual field defect correlates very well with the region of the RNFL thinning, and the adjacent region of RNFL on the OCT also shows suspicious thinning. So that was about the Cirrus OCT interpretation. Now we'll quickly look at two other commonly used OCT machines. One is the RTVue or the Avanti. The report of the RTVue looks slightly different. However, the interpretation is very similar to what we did now. First is the region of patient details. Look for age, date of birth here, age, if it is mentioned right. Then we have two maps, both the optic nerve head map, which gives the optic nerve head and the RNFL thickness measurements, and the GCC map. GCC stands for ganglion cell complex, which is in fact the inner three retinal layers. Unlike the Cirrus OCT, which evaluates the inner two layers, RTVue evaluates the inner three layers together called ganglion cell complex. And there's a significance map here, which means that the GCC thickness in the macular region is compared with an age-matched normative database and age-matched reference database, and color coding is already given. The quality of the scan using the signal strength index is represented below. Generally in RTVue, any signal strength of over 45 is considered to be acceptable, and lower than 45 is low signal strength, which needs a repeat scan, or we'll have to exercise caution before interpreting it. We have the T-SNIT graphs similar to what we saw on Cirrus reports, and a table here of all the summary parameters. Two important parameters to note in the RTVue printout is the FLV and the GLV parameters on the macular scan, which stands for focal and global loss volume. These are two proprietary parameters which are provided by the RTVue machine. An example of a normal and an abnormal and a glaucomatous eye here, the right eye being normal, which shows normal RNFL thickness and normal GCC thickness. The left eye shows superior RNFL thinning and a corresponding thinning in the superior GCC region, which are once again seen on the summary table as well. And as I said, the FLV and GLV of the left eye are significantly higher than the normal. So the loss volume is higher in the left eye compared to the age-matched normal. So FLV is more sensitive to focal defects in the GCC thickness, and GLV is more sensitive to global or diffuse defects in the GCC thickness. A quick example here, this is the glaucomatous eye showing inferior rim thinning with the inferior retinal nerve fibrillary defect. Visual field once again showing a paracentral defect in the superior hemifield. More obvious on the 10-2 as well. And this is the GCC map of scan of this eye, which shows inferior RNFL thinning corresponding to the RNFL defect which we saw on the disc photograph, and the thinning of the GCC in the inferior region once again corresponding to the defect which we saw on the 10-2 visual fields. The other most commonly used OCT machine is the Spectralis from the Heidelberg. This is how a report of the Spectralis RNFL report looks like. Interpretation is once again very similar. We have the patient details. Then we have the RNFL calculation circle here in SLO image, which shows the calculation circle in green. And there's a blue line which passes from the fovea to the center of the disc. This is called the fovea disc axis. This is a unique feature of the Spectralis machine, and the subsequent evaluation of the RNFL happens around this axis, while most of the other OCT machines consider as horizontal line here as the axis over which the RNFL measurements are done. The other important region is the tomogram. Because of the higher resolution of OCT, the segmentation of the RNFL is better seen on the Spectralis reports. The other one is the T-SNIT profile graph, very similar to the T-SNIT profile graphs of the other OCT machines. And the other region is the region of the RNFL thickness in quadrants and the 6 sector maps of Spectralis. Once again, not very different from what we saw at the other OCT machines. And all of them, once again, are color coded based on how similar or different the patient's RNFL thickness is compared to the age-matched reference database within the machine. There is also an overall classification which represents the average RNFL thickness classification. Here is an example of a normal patient on the left eye and a glaucomatous patient on the right side. As you can see here, all the parameters are in green representing normal. But in the left eye, we see that there is the inferotemporal thinning of the RNFL in the right eye and superotemporal thinning of the RNFL in the left eye. The other unique feature of Spectralis is a very detailed evaluation of the optic nerve head. The optic nerve head margin, once again, on Spectralis is based on Brooks membrane opening called the BMO, which is a more consistent anatomical landmark of the disc margin rather than the clinical disc margin. And unlike the rim area and the average cup disc ratios, which are provided by the other OCT machine, the optic nerve head parameter, which is evaluated in Spectralis, is called the minimum rim width or the MRW, which is in detail evaluated in 6 sectors, and a T-SNIT profile of the minimum rim width is also provided by the machine on the reports. The other unique feature of the Spectralis macular scans is the evaluation of the individual retinal layers at the macula. Here we see example of the GCA thickness and the IPL thickness separately of this eye. Both of these in a normal eye. We also have a superior and inferior asymmetry analysis here. If there is a gross asymmetry in this between the superior and the inferior hemispheres of the macular thickness, we know that something is wrong. And here is a glaucomatous eye which shows the thinning of both the GCL and the IPL layers in the inferotemporal region here, which is once again shown well on the symmetry maps. You can also see that the measurement is happening around the fovea disc axis here, which is called the anatomic positioning or the APS, which is once again a unique feature of the Spectralis OCT. So that's a brief overview of the reports of 3 different OCT machines. One important point to note here is that if there is one most informative region of the OCT reports, it's the thickness map. I'll show you a couple of examples highlighting this aspect. Here is an example of a glaucomatous eye with the inferior RNFL defect seen more clearly on the red-free photograph. The visual field shows a nasal defect in the superior region corresponding to that region of RNFL defect. If you look at the OCT of the right eye, the corresponding eye, Signal strength is good. Segmentation is good. We'll come to segmentation subsequently also. But if you look at the quadrant and the Clark-R maps, everything is in green here, which means that the RNFL thickness of this eye is similar to a normal of this age. The deviation map once again is clear, which says that even if you look at smaller regions over the superpixels, the RNFL thickness of this patient is similar to a normal of this age. However, if you look at the RNFL thickness map, we see that the pattern is disturbed with the inferior RNFL showing this region of RNFL thinning very obviously on this thickness map, which wasn't obvious on the other maps. So if you just go by either the Clark-R or the quadrant maps or even the deviation map, the glaucomatous damage of this eye is likely to be missed. So RNFL thickness map is the most informative map here. Another example of a glaucomatous eye with a bipolar thinning with a broad RNFL defect superiorly and a smaller RNFL defect inferiorly, with very correlating visual field defects, more denser defect inferiorly corresponding to the superior region of broader RNFL defect, and a smaller nasal defect superiorly corresponding to the smaller wedge-shaped RNFL defect inferiorly. However, if you look at either the quadrant or the Clark-R maps or even the deviation map, it doesn't show such an obvious thinning of the RNFL either superiorly or inferiorly. However, if we closely evaluate the RNFL thickness map, we see this region of RNFL thinning, that brightness is gone, and we see that smaller area of RNFL thinning also very clearly in this region on the RNFL thickness map. So that's the point which I wanted to highlight using these examples. Another important point is to pay attention to the segmentation, as I already have told you. So here we have the RNFL circular tomograms, as I said earlier. Here, the anterior and the posterior border of the RNFL, which the software has segmented out, is shown on the tomograms. It may be very difficult to look for minor defects in the segmentation on these tomograms. However, gross defects would become very obvious. Like in this example here is the GCA map, the macular scan. If you look at the segmentation here, it is obviously wrong here. So we know that the measurements provided or the analysis which is happening using this segmentation error would obviously be wrong. If you retake a scan and the segmentation is better, then we see a more reliable measurements of the macular region. One common reason for segmentation errors is low signal strength. Here are two scans of the same eye, one with a poor signal strength and another with an acceptable signal strength. We see that the clarity of the segmentation is not that great here compared to the scan below. And if you look at the measurements of the RNFL either in the Clark-Rs or if we will just look at the quadrants here, look at the difference in the RNFL thickness in each of the quadrant. The superior quadrant, which showed a RNFL thickness of 69 microns, is now showing a thickness of 83 microns, a significantly higher thickness with better scans and a better segmentation. Inferior quadrant showing an RNFL thickness of 85, now is showing a thickness of 98 microns. So this is the importance of good signal strength, and this is the importance of making sure that the scans don't have segmentation errors. These small differences become very significant while we are evaluating for progression or looking for RNFL thinning over time. We also have to pay attention to the ocular characteristics before we interpret the OCT scans. Here is a tilted disc. So if you look at the disc here, clinically this disc looks non-glaucomatous, very healthy. If you look at the RNFL map here, the pattern of RNFL thickness also looks perfectly fine. We see bright RNFL bundles superiorly and inferiorly. However, there is a slight anti-clockwise tilt here. So which means to say that the thicker inferior RNFL, which should have been present more nasally, has moved more temporally, which is causing a false defect to be present on the deviation map and the Clark map. And the thickest RNFL superiorly, which is supposed to be present more temporally, has moved nasally, so causing a artifactual defect in the superotemporal region, both on the Clark map and on the deviation map. If you imagine a slight clockwise tilt to the entire scan, then you could visualize these defects going away. The other important ocular characteristics to pay attention to before the interpretation is to see whether the disc is myopic. So a myopic disc leads to a lot of anatomical changes compared to a normal disc. Like there's enlargement of the peripapillary atrophic region. There is a tilt to the disc. The nasal margin is elevated. The temporal margin goes down or is flattened. And the RNFL bundles insert into the disc in a more oblique fashion. So all these can cause problems with the OCT interpretation. We will have to remember that the OCT is not designed to evaluate the RNFL in a myopic eye. However, we most of the times use OCT in myopic disc evaluation as well. So the OCT scan of the same disc, as you see here, has caused the thickest RNFL bundles to move more temporally. It's called the temporalization of the RNFL bundles, which obviously leads to an erroneous thinning, which is shown on the deviation map and the Clark and the quadrant maps in the superior and inferior region. The other important question which most of the times is asked is, which OCT parameter is important in glaucoma? So we saw the RNFL thickness, we saw the inner retinal thickness at the macula, be it the GCAPL, be it the GCC. We also saw the rim widths or other neuroretinal rim parameters. Which OCT parameter is important in glaucoma? So I'll show you a couple of examples here to make the point clear. Here is a glaucomatous eye with inferior RNFL defects in both eyes. The visual field shows a paracentral scotoma in both eyes based on 10-2 visual fields. If you look at the RNFL and the GCAPL scans, once again the Clark and the quadrant maps of the RNFL scan and the deviation map of the RNFL scan are absolutely normal. However, the macular scan shows GCAPL thinning in the sector map as well as in the deviation map, which is very obvious and it's quite large in area. So does this mean that the GCAPL is better than the RNFL? In fact, not. So if, as I said earlier, we will have to pay more attention to the RNFL thickness map. On that thickness map, we see this region of RNFL thinning very well in the right eye and in the left eye. But what unfortunately has happened is that the region of RNFL thinning is more closer to the macula, which means they are more temporally located, which is one of the reasons that they are not picked up very well on either the deviation or even the smallest Clark maps. So if you now evaluate the RNFL maps, then we can see the presence of the RNFL defects. We can see the presence of the defects on RNFL scans as well. So in fact, the GCAPL or the macular parameters are not superior to the RNFL parameters here. It's just the way how we look at the scans, which is important here. Also, the other important thing is that This depends on the location of the damage. To highlight this fact, I have an example here. These maps are called the pano maps, where the optic nerve head map and the macular maps are placed next to each other to have a better view of the structural defect. Here is the thinning in the inferior RNFL region shown on the deviation map, and there is a corresponding thinning of the GCAPL in the inferior region as well. So a defect in the inferior hemisphere, which is seen both on the RNFL and the GCAPL. So both the RNFL and the GCAPL correlate here, and both parameters are showing the glaucomatous damage very well. However, if you look at the right eye shows RNFL thinning inferiorly, which is larger, and the superior RNFL thinning, which is smaller. However, there is an RNFL thinning both in the superior and inferior region. If you look at the macular map here, so this RNFL thinning in the superior region is beyond the macular scan. So here, that's the reason the GCAPL map is not showing an abnormality in the superior region at all. The superior hemisphere of the GCAPL scan is totally green, totally normal, while the defect is only shown on the inferior region. So the point which is to be noted here is that if the structural damage is closer to the fixation, closer to the macula, then the RNFL parameters pick up, the macular parameters pick these defects up very nicely. However, if the structural damage is away from the macula, here is the RNFL damage away from the macula, the macular parameters don't pick these damage very well. So whether it is the RNFL or whether it's the GCAPL or the GCC parameter, which is more important in diagnosing glaucoma or even in detecting glaucomatous progression, depends primarily on where the structural damage is, and no one parameter is better than the other. Both of them are complementary to each other. So a quick note on how we interpret OCT for progression. We can use OCT scans to detect progression in multiple ways. One is a clinical judgment method. The other two are algorithm-based evaluation, which is the trend and the event analysis. We'll quickly go through each one of them. The clinical judgment is a subjective observation of sequential reports to see if there is any change in the RNFL or the GCAPL, which is happening, thickness, which is happening over time. So here are two scans done 2 years apart. So if you look at the 2013 scan and the 2015 scan, we can compare what is happening in the superior quadrant. The RNFL thickness, which was 87 microns, has become 78 microns now. The inferior quadrant RNFL thickness, which was 94 microns, has become 89 microns now. We can take a closer look at what is happening in these hemispheres by looking at the clock hour measurements, and we see that the clock hour measurements are also decreasing over time, both in the superior and inferior region. So we would know that the RNFL is thinning both in the superior and inferior region in this. However, this method has a few disadvantages. It is time consuming, and we also need to know the test-retest variability of these measures. So the change which we see over time on the OCT scans can just be a representation of the normal variability of the measurement, but not a representation of the true thinning which is happening over time. So that's the reason we don't use that, and we move to software-based methods of detecting progression. One is the trend analysis, as I told earlier, which is basically what is happening to a parameter over time. So this gives us the slope or the rate of change of a parameter over time. And the other one is the event analysis, where an event is defined to have occurred if the parameter crosses a certain threshold. So if the RNFL thickness, for example, crosses a certain threshold or changes by 10 microns, then it is said that the event of progression has happened. So that's what an event analysis tells us. Trend-based analysis is very common. We use most of the global parameters or even the quadrant parameters to see what is happening to them over time. Here is the average RNFL thickness and how it is changing with time. Superior and inferior RNFL thicknesses, how they are changing over time when multiple scans are done repeatedly over the follow-up period. And we also see that the rate of change or the slope, as I said earlier, here, these are the measures which says that the average RNFL is reducing at a rate of 2.8 microns per year. The superior RNFL, in fact, is reducing at a faster pace of 5 microns per year. And the inferior RNFL is also thinning at a rate of 3 microns per year, is what the trend analysis of the RNFL is saying. Similar with the GCA APL thickness, be it the average, be it the inferior or the superior GCA APL thickness. Most of the OCT machines use trend-based analysis. Here is the trend-based analysis report of the RTVue OCT, which gives us the RNFL rate of change here and the GCC rate of change in graphs. Here is an example where the RNFL is changing at a faster rate compared to the GCC thickness. So does this once again mean that RNFL is better in detecting progression compared to GCC thickness? Maybe, may not be, but as I said, it depends on where the initial damage is. Spectralis also gives a trend-based analysis both of the global RNFL thickness and of the global rim width. It gives a p-value of how confident we are about a trend, either a downward or an upward, mostly downward, which is what we are interested in, and the rate of change as well. Here it says that the RNFL is reducing at a rate of 1.5 microns per year, which is statistically significant at a p-value. It doesn't mean that it has to be clinically significant as well, but this is what is the rate of change happening, is what the OCT tells us. However, this linear regression analysis to detect progression also has multiple limitations, which we will not go over. It probably will be discussed more elaborately in other presentations of this module. The most important progression analysis algorithm is the event-based analysis. Here, the Cirrus has a more elaborate event-based progression analysis algorithm. There are two, in fact. One is called the RNFL thickness and the change map. Here, the change in the RNFL thickness, if it is beyond the normal variability of the RNFL thickness, is color-coded first in orange and then in maroon, which means that the RNFL in this particular region is showing a significant deterioration. The variability is once again determined by the machine itself, and the significance is also dependent on the region over which that change is happening. If it is too small, it is not highlighted, but if it is happening over 20 superpixel region, then it is considered significant and is highlighted in the color region. Here is the RNFL, here is the GCAPL map. Both of these maps, the change map is based on the same principles. In both these examples, we see that the RNFL is thinning compared to the baseline examination. The GCAPL is thinning compared to the baseline examination. The other event-based progression map on the Cirrus OCT is the RNFL thickness profile map, where the change in the T-SNP profile over time is highlighted. And if there is a significant reduction in the RNFL thickness at any particular region of the T-SNP graph, which is more than 20 degrees out of these 360 degrees, if it is more than 20 degrees, then it is highlighted to be significant and is highlighted on the progression report. which we will see subsequently here. So this is the overall progression analysis report of the Cirrus OCT. Here we have multiple ways by which progression is analyzed. One is the thickness map progression, which we saw here, the baseline maps and the follow-up maps. And if there is a significant region of thinning which is highlighted, then the RNFL thickness progression map has a tick here. Then the RNFL thickness profile progression, as we discussed earlier on the T-SNP profile, and then the average RNFL thickness progression, which is a trend-based analysis, as we can see here, and an average cup to disc ratio progression, which is not so important because we don't pay attention to the optic nerve head parameters so much, both for diagnosis of glaucoma and for detection of progression. And similarly on the macular map also, macular scan also, we see both the trend analysis here as well as the event analysis of thickness map progression here. Here the thickness map is not showing a progression, while the trend analysis is showing a progression in this example. And one last example of progression here, this is an optic nerve head, a glaucomatous optic nerve head, which showed a inferior temporal disc hemorrhage. This was how it was in 2016, 2018, showed a disc hemorrhage. And next year, the disc hemorrhage has regressed, leaving behind a frank inferior retinal nerve fiber layer defect on the disc photograph. And this is how the progression report of this eye is, as an obvious thinning happening in the inferior RNFL, an obvious thinning happening in the inferior GCA-PL temporal regions as well. And almost all of the progression analysis algorithms are pointing towards likely progression here. In fact, in this example, the visual field remained normal till 2008, till this point, in fact. But by this time, the RNFL progression and the GCA-PL progression had become very obvious. The visual field did not show any sort of visual field defect till then. So before we interpret the OCT reports for progression, we will have to be very clear about the quality of the scans. And before we confirm progression, we will have to see whether the region of the progression, how it relates to the position of the original defect. And we'll also have to always look for accompanying clinical signs like fluctuations of the intraocular pressure, or in fact look for any accompanying signs of visual field progression as well. And whenever in doubt, it is always better to repeat the test. One drawback of the OCT in detecting progression is the floor effect. Floor effect is that the RNFL and the GCA-PL, any of the OCT parameters, reaches a floor at certain severity of visual field damage, beyond which, even if the glaucoma progresses, the structural parameters don't show subsequent change. Here in this example, we see that the visual field is showing an obvious progression here compared to the baseline visits, but the RNFL is not showing any progression whatsoever, primarily because the RNFL has already reached a floor to begin with. And beyond this level, even if any true progression happens, RNFL is unable to detect such a true change. Few studies have shown that the macular parameters, the GCA-PL or the GCC, is better than RNFL in detecting progression in moderate to severe advanced glaucoma cases. However, once again, all these have to be clinically correlated. So to conclude, OCT has changed the way glaucoma is diagnosed, glaucomatous damage is quantified, and stability or progression is monitored. However, the OCT findings have to be interpreted with the understanding of the analysis algorithms and their and other limitations of OCT and the presence of artifacts which can make our interpretation erroneous at times. Thank you.